You'd like to take your seats and then we'll give it the official go for the recording. Yeah, are we all good? Thank you. Good morning, everybody. Welcome to the Health and Wellbeing Board on the 22nd of January. I'm in the chair today. I'm normally vice chair, but we have apologies from Paul. This is recorded. As Paul would normally say, just be mindful of that. If you're looking at any devices or anything like that, it may be seen on the recording. We're going to do introductions in a minute, but first we'll do apologies for absence. So Heather, do we have apologies, please?
Yes, Chair. Councillors Chicken and Eshel Shelvin.
Thank you. And also Neil Bradley. Today there are some interviews for the Chief Fire Officer, I think is the correct title. So Neil sends his apologies because he's involved with the interview panel for that. We have 4 items on the agenda, so that's quite a packed agenda, so hopefully we can move along efficiently today, please. We're going to do some introductions in a minute and go around the room. Before we do that, can we agree the minutes of the last meeting, please? Happy to agree, and I can approve them. Thank you very much. Right, so I am going to ask the gallery to introduce themselves because we have a bit of a minstrels gallery today as well due to the number of people and the items on the agenda. So I am Graham Sayers, I am a GP in Northumberland and I am a clinical lead with North East North Cumbria ICB for the North Tyneside and Northumberland patch.
Morning everyone, Jill O'Neill, Executive Director for Public Health, Communities and Inequalities at the Council.
Morning, I'm Chloe Mann. I'm a Place Director covering the North locality and I work for CNTW.
Good morning, I'm Abby Conway, Chief Executive Citizens Advice, representing the voluntary sector through Thriving Together.
Morning, I'm Sharon Williams. I represent Community Pharmacy North of Tyne.
Hi, I'm Carl Green. I'm a County Councillor for Spittal and Seaton with Spittal, which is in Ashington and Newbiggin.
Hello, good morning. I'm Hugh McKendrick, the Chair of Health Watch Northumberland.
Morning, I'm John Caseley. I'm Chief Inspector for Communities for Northumberland Area Command.
Good morning, I'm Deborah Brown, representing Northumberland Fire and Rescue Service.
Morning everybody, Audrey Kingham, Exec Director for Children, Young People and Education in Northumberland.
Morning everyone, Vicky McLeod, Director for Children, Young People and Families in Northumberland.
Hello, Rob Murphy, Director of Housing and Planning at the County Council.
Morning everyone, Emma Benjames, I'm the Safeguarding Adults Business Manager for the Children and Adults Safeguarding Partnership.
Morning everyone, I'm Sarah Park, I'm the Children's Business Manager for NCASP.
Hi everyone, I'm Anne Lawson, Public Health Manager, responsible for tackling inequalities through housing and planning.
I'm Lee Robinshaw, Deputy Director of Public Health.
Heather's busy, right? Are you going to introduce yourself, Heather?
Heather Bowers, Democratic Services.
Thank you.
And Jim Brown, Deputy Director of Public Health at Northumberland County Council, and I think I'm first on the agenda.
Perfect, thank you. So that takes us to item 3, any disclosure of interests from anybody regarding any items on the agenda. Haven't received any in advance. Thank you. Item 4, the annual report of the Northumberland Health Protection, Assurance and Development Partnership. This was to be introduced by Eve Chicken, but we've had apologies, therefore it's straight to you, Jim, to take us through. Thank you.
Thank you, Chair. Great. It's there as if by magic. Thank you very much. Great. I'll just make sure this is working. down, yeah. Okay. Great. Oh, well, thank you very much for this opportunity to provide an update from the Health Protection Assurance and Development Partnership. This is the third report from the partnership, and I'll be really sharing some of the kind of key health protection issues and data from the past 12 months and the multi-agency activity and the kind of areas of development that we've seen over this past year. Although it's a third report, just very briefly, I'll remind everyone, as it's been 12 months since I was last here, about what the role of the health protection, I'll just call it the partnership, if that's okay. It's really to, first of all, provide assurance to this board that adequate arrangements are in place for the prevention, surveillance, planning, response required for the health of the local population. Second, it's a forum really for members to kind of identify and agree developments to improve health protection arrangements and our response in Northumberland. And then really finally, just really it's where we can have that local strategic response to significant events such as a pandemic, and I'll be talking about our Northumberland County Council pandemic plan in this presentation. And just a final recap, just in terms of the kind of the role and the membership of the partnership. It's broad, and actually many of the members of this board the organisations have representatives. We have a lot of contribution, obviously, from our UK Health Security Agency partners at the Health Protection Team in the North East, which actually is soon to be combined with Yorkshire, so it'll be a much bigger footprint, but hopefully won't see any change in the superb service that we have from the Health Protection Team in leading outbreak responses and management cases, together often with our Northumbria Healthcare Infection Prevention Control Team, who are key members of our partnership, but also other parts of the NHS, CNTW, our general practice colleagues, ICB, NHS England, who commission screening and vaccination currently, but also actually right across our council team, not only public health, and I chair the partnership, but also our public protection and civil contingencies teams as well, who have a really key role. So I'll get into the bones of really what we kind of cover. We broadly cover about 6 themes: prevention control of communicable disease, including health and social care associated infections in community settings, that's particularly care homes, but actually other community settings as well, emergency planning, environmental hazards, immunisation, and then finally cancer and non-cancer screening. It doesn't automatically fit in health protection, but it's actually a really useful place to be looking at some of that data because of the fact that NHS England screen these things from the same team. But actually we've had a particular focus on sexually transmitted infections and bloodborne viruses this past year, and actually that's where I'm going to just start in terms of some of the key issues that we've seen, that we're seeing. Although actually we've seen overall decreases in STI cases, and chlamydia remains actually the most common STI, we have actually seen some increases over a couple of STIs. We saw a dip really in all of the detection of all STIs during COVID and the lockdowns, but then actually a big rebound afterwards. And actually what we're seeing in Northumberland is gonorrhea cases higher than they were pre-COVID. And that is really important. Not only do they cause unpleasant symptoms, but it's a serious cause of infertility and ectopic pregnancy. And we're seeing also increasing numbers of antibiotic-resistant gonorrhea cases as well. What's the good news is obviously we're lower than the England average, but obviously there's still work to do, and the sexual health strategy is a key place where we're seeing that work directed, and we have an excellent sexual health service, and I know you've had the sexual health strategy presented at this board in the past, and they'll be doing an update later in the year. So the other STI, which many of you might have thought was something we haven't seen for decades, has actually been the rise of syphilis. And we've actually got the highest rates in England since World War II. And we've seen a rise also in Northumberland, actually quite a steep rise, albeit actually if you look in terms of this right figure, it's from a low level. So the numbers remain, relatively small, but we've seen this steep rise. Whereas with gonorrhea, it's actually been fairly equal between men and women, and it's generally been young men and women. For syphilis, we've seen the rise in men who have sex with men. So there's been a lot of work with GPs for the detection of syphilis, because it actually can have some very severe symptoms, and it has a 15% mortality when untreated, but it's eminently treatable with antibiotics. One of the kind of areas of good news has been hepatitis C, which is one of the bloodborne viruses, along with hepatitis B and HIV. And what we've seen is actually the numbers of people with hepatitis C in England has come down, and that's been through improved detection, but also that there is now available, and there has been for about 10 years, curative treatment. So there's been a lot of work, particularly by our Northumberland Recovery Partnership, in testing people for hepatitis C and referring them for that curative treatment. And that's part of what's known as a Hep See You Later, which has been an NHS England initiative. And our team's working really in NRP, which are working really closely with them. NRP being the Drug and Alcohol Treatment and Recovery Service provided by CNTW. I thought we've already had a mention of flu today. I couldn't mention today without a little bit of update. Obviously, this isn't really in the report, but what was in the report was that seasonal flu activity appeared to have started early. Well, it had started somewhat earlier, maybe a couple of weeks earlier than usual, this 2025-26 winter season. And also there were concerns about a particular subtype associated typically with more severe illness and mortality. But the good news is that really since a peak of about early December, we've seen a drop in cases. So in terms of on the left, that's the proportion of tests that test positive. And on the right is hospitalizations across England. And we've seen actually a drop since that. So actually, a great relief that we haven't seen quite the levels that we were concerned about. One specific development has been a lot of work around 2 to 3 year olds this year, where there was a small amount of inequalities funding, and that went into supporting our school age immunisation service at Northumbria to provide not only what they were providing flu vaccination to primary schools and to secondary schools, but also for those nurseries attached to the primary schools. So they were saying, well, look, we walked straight past them. But previously had quite low rates of uptake, and as you can see, about half, although, which is fantastic compared to the rest of the North East and certainly compared to the rest of the country. But through this work, they've managed to increase that further and increase the uptake about 2 to 3 year olds. And that's really important. Not only, do they have relatively higher rates of hospitalization, but also a key kind of vectors in terms of, passing on to more, to other vulnerable elderly relatives as well. I think what you can see as well is that really Northumberland performs, fantastically in terms of flu vaccination compared to other areas, but we really don't rest on our laurels. Because actually, if you think of the under 65s, people with clinical conditions at risk, it's still only about half of people who are getting vaccinated. So it's still a lot of work to be done. Age 65 or over and care home residents is kind of closer to 80%, and still higher than other parts, but obviously we'd like that higher. There's been a lot of work again this year to intensify that support for pregnant women through family hubs, through additional clinics, through a lot of communications and engagement, and that has seen a really good rise in the proportion of pregnant women who are getting vaccinated. And similarly, we've seen that for frontline healthcare staff. We've seen a rise. I can't share the data through kind of permissions from last. It's not in the public domain, but what we have seen is a rise this year, which is fantastic. So I said that kind of screening is part of the partnership's remit. And one kind of development this year has been to include some of the non-cancer screening programs, such as diabetic eye screening and aortic aneurysm screening. We have a screening inequalities group that reports into the partnership that really tries to link some of those community groups, the people who work into communities with the providers so that, and with GPs so that they can increase the uptake. And one of the areas we've seen diabetic eye screening, which is really about trying to identify early some of those people with diabetes who have changes and therefore offer treatment, and it's via a mobile van. One of the things we've seen is actually really quite marked inequalities in terms of the non-attendance for diabetic eye screening. So if you live in one of the most deprived areas, so IMD 1, then you're far less likely to be coming for your diabetic eye screening, and which is hugely protective. So through that work, we've looked at that data, and that has meant that the provider in health has been able to work with some of the GPs with high levels of non-attendance, but also provide more accessible solutions. So go into some of those areas where we know that where there's higher non-attendance to try to address some of those inequalities. So other kind of issues that we've seen over the past year, you remember Mpox was something that we saw kind of coming out of the lockdown. That was a different subtype, but what we are seeing is actually globally a separate subtype, what used to be known as monkeypox. But Mpox is, we now see kind of community transmission globally. Thankfully, cases are low in England, in the UK, but NHS England have brought in a vaccination campaign which is run through the Sexual Health Service. So one of the other kind of key changes this year has been the addition of chickenpox or varicella vaccination to routine children's immunisation schedule. So the way that's working, that's from this month. It's been combined with the measles, mumps and rubella MMR vaccination to have what's now an MMRV. But already that MMR had been brought forward to 12 months and to 18 months for children, really to get it in a little bit earlier, because it was often that second dose that children were not getting, and we're hoping that will improve that uptake for second doses. We actually have really good rates, and 93.5% of children, by the time they're 5 years old in Northumberland, have had 2 doses of MMR, which is highly protective. I mean, 1 dose is very good, 2 is really protective. We're hoping to see that kind of increase with this move to 18 months, and then obviously some protection from chickenpox. And what the kind of particular issues there, although it's a fairly common illness that most of us will have had, the Joint Committee on Vaccination and Immunisation have made a decision that actually the benefits can outweigh any of the risks from having varicella vaccination. In terms of the risks, I think the concern was that would it put people who hadn't been exposed to the virus in childhood at high risk, but actually the assessment is it reduces the risk for everyone, but also reduces that risk of shingles, which is also harmful in older age and linked to having had chickenpox. Other kind of issues, despite the wet weather today, one of the things we saw through kind of last summer and into the autumn was with prolonged dry weather and our rural and farming communities, a lot of pressure on some of the private water supplies. So there's a lot of work of the council working with Northumberland Water and with some of those private water supplies to try to find some of those solutions. But also, we work with Environmental Health. We go out and do visit 3,700 premises to do look at food standards. There's been they brought in an assessment around allergen information into that assessment as well. So I'll come on to other kind of key developments. One of the big pieces of work this year has been the Northumberland County Council Pandemic Plan. And really what's prompted that is a national assessment that the risk of a pandemic plan, I might have mentioned, risk of a pandemic in the next 5 years is somewhere between 5 and 25%. So not insignificant. We might be kind of saying it's, when it's going to happen, not if. And I think we've all probably got still quite vivid memories of both personally, professionally, of the last pandemic. Really what I've tried to kind of cover here is just some of the areas that I think are particular focus from a local authority perspective. I mean, the first, we had a particular role around supporting the outbreak, control, containment in the last pandemic. We supported care homes, we supported education, we supported our own staff, we supported businesses, and that's been a really important part of it. Actually, we also had a role in supporting some of that contact tracing, and I think we expect that local authorities may well have a greater role in supporting our AXA and other colleagues in contact tracing, and that's really what that top left is about. I think a particular role for a local authority is in supporting some of our most vulnerable groups. So really I've given an example around sort of rough sleeping, but it's a really important part of what we do to try to minimise the inequalities increasing as a result of a pandemic. So a lot of the pandemic plan has been focused on the kind of work, the kind of data that we need to be using so that we can support some of those groups. But there was a huge amount of work done whether around food parcels or around eliminating any rough sleeping, around supporting people to access medications, addressing some of those social isolation issues. And then another key part of it is make sure that we can maintain some of those critical services when we know that there will be massive staff absences, possibly even higher than last time if there were different types of scenarios. And actually that's going to be a key part of what the pandemic response would look at. But probably one of the bigger changes we would expect if there was a pandemic in the next couple of years is that the rise of kind of misinformation and disinformation will probably make it even more important that the council is a trusted is trusted in terms of how it communicates, engages with our communities. I think we expect that there may well be much greater levels of community tension in response to lockdowns. I don't think that's definitely the case, but I think that will certainly be the case. And certainly how we communicate about risk and how we make sure that there's a kind of honest conversation with our communities are really important. And part of that is about building those links with trusted voices into our communities, about valuing the voluntary and community sector as a really trusted partner, so that we have that reach into our communities in a future pandemic. That's a vital part of what the plan is looking at. And then finally, but last but not least, and you'll see from the next slide, there's actually, there's a huge range of different areas that we've covered, is around the kind of logistics. One of the really important part was actually how we make sure that PPE gets to the people who need it, how we make sure we have the sites for vaccination, for testing, potentially storage and distribution. And I mean, the fire service had a key role. I know the highways team, a whole lot of people had a key role. And actually that's one of the areas that we focused on in the plan. So just very briefly, the way it would look in terms of when the plan was activated, EMT, so the executive team would be the strategic coordinating group. Tactical coordinating group would include and this is within the council. It's different from the Local Resilience Forum. Just looking at our police and fire colleagues who might have a different look at, think of the way that SCG and TCG looks. But this TCG, the Tactical Coordinating Group, would be the lead officers for a range of different cells that we'd set up, ranging from communications, business continuity and redeployment, staff well-being, and and a range of other areas that we're going to need. One of the other groups is set up is around an immediate focus on recovery and inequalities, and also some of these groups would expect to report into the Health Protection Insurance Development Partnership, which would be the focus around outbreak control. And then we would hope that the Health and Wellbeing Board, as it was in the last pandemic, would act as the Pandemic Control Board, and we'll just invite that when the terms of reference are next being amended, we just make sure that that's in there as more formally. So otherwise, I've mentioned about the work around hepatitis C. One of the other kind of developments has been a vaccination engagement group, so really focusing on those inequalities in vaccination. That's something that we've developed. There's a wider local immunisation steering group led by our RCB colleagues with North Tyneside. But this group, the engagement group, particularly focuses on inequalities. I've mentioned about the work around 2- and 3-year-olds and vaccination. And I've mentioned about expansion of the Screening and Inequalities Group. one of the really important developments, I think, this year has just been strengthening some of the governance arrangements around emergency planning. So we now have an emergency planning oversight group, which I think is working exceptionally well. Jill, you may want to talk about that as well, as Jill is the chair, and we've seen the publication of the Northumberland Air Quality Strategy. Some of the developments of focus for next year will be a self-assessment against quality standards. I think we've been running for about 3 years, and it's a really good time to check that our arrangements are really robust. We'd like to just improve some of the quality of hepatitis B testing and vaccination, and that will be a little bit of a focus. And then really, given some of the issues around flooding, around pressure on private water supplies, maybe work with our climate change team to understand what some of those health impacts are likely to be in the future. And I know they're developing their adaptation plan, so it'd be great to link in with them, and I've already made contact to make a plan in the diary for that. So a recommendation for the board today is for you to really note and comment on the wide range of activities of the Health Protection Insurance Development Partnership, and particularly some of those key issues that I've raised today. Thank you.
Thank you, Jim. That was a really nice, comprehensive presentation. I'm going to open it to the floor. We've got about 5 minutes or more just to have a think about this. Any comments or any things that people would like to propose based on that? While you're thinking, there was a couple of things that I thought about. One is a comment about the varicella vaccinations and the MMR rates. I think it's really clever that they've combined the two, in that chickenpox is really real, and lots of parents are coming to us already saying, when can we get the chickenpox vaccine? And actually they'll get their MMR as well. So I think we'll see vaccination rates, especially the second ones, going up, because actually it means parents have to have time off work, their kids can't go to nursery, it's a real inconvenience, whereas MMR doesn't mean anything to them these days. So that was one really interesting thing. I think we'll see it go up. The other one was a little bit about, as a GP, I have noticed some families moving into my area who are Afghan refugees families, and they have real challenges about accessing our healthcare, and we have challenges about providing the best healthcare for them, and they come from areas where they've had major trauma and also been exposed to many of these illnesses that us GPs just don't quite know how to detect or how to handle. And I just wondered if there was scope for an out of this room meeting just to think about that group of our population and how we might educate our primary care practitioners around some of their needs to try and address some of the issues that you identify in here, because I think some of those issues will be involved in here.
Yeah, thanks, Graham. I mean, first of all, I completely agree around chickenpox. I think all the evidence suggests that parents actually, we might think there's some people who are vaccine hesitant, but actually most parents are very keen to have their children vaccinated. And when asked, I think there was a big survey, about 2,000 parents, they were keen to have it combined, in with the MMR. In terms of, I think, the refugees and asylum seekers, I think you make a really, really good point. That's a particular area of focus for our vaccine engagement group, and actually done quite a lot of work working with the County Sanctuary, but actually a lot with some of our practices with higher numbers of people who are refugees and asylum seekers, really just to do some of that work to check. I know that there were some issues that actually they may have been vaccinated, but some of the times the records don't kind of follow through. But and we're going to we're looking into some of that hepatitis B testing, vaccination as well. But I think you make a really good point. But actually, it's the wider health needs that need to be considered. So one of the kind of developments is a multiple and complex needs steering group that we've developed that's initially council but widening up, and that's really going to focus on some of those groups around substance use, homelessness, offending, vulnerable asylum seekers and refugees, and people who are perpetrators and victims of domestic abuse. Now, it's not saying that those are all the same. That's not all the same people, but we know that there's particular support needs and particular ways that we can be less fragmented as a system to support people who often have, two or more of those, those criteria, and that's a particular area of work we're going to focus on. But I think actually it'd be really good perhaps to think about some of those wider health protection needs for that group. And I know tuberculosis, I was going to mention today, the rates are so small that I didn't want to make such an issue of it, but we are seeing an increasing number. of people with tuberculosis. So I think that's a really, really good call. So I'll definitely take that forward.
Any other comments?
Thanks, Chair. Thanks, Jim, as always, a really comprehensive presentation and report. 3 brief comments from me. First of all, we can't ever be complacent around the strength of partnership that we have in Northumberland. I know we work really hard to make sure that the agendas are engaging, they're relevant, and also cross-purpose. So it's a real positive, and also, as you say, timely to take that stock take next year to make sure it remains fit for purpose, because what we have to have is that continued engagement to make this a system impact, and we're seeing that come to fruition with the likes of the inequality work that we're doing on vaccination. So some of those stats around the 2 to 3 year olds, it is absolutely a team sport to get us to that stage. So really important that we continue with that, and the more we can do as a board to make sure if you do have any gaps in attendance that gets flagged for us to be able to push and persuade people to participate. Secondly, the pandemic plan. It is very emotive still, I think, for many people in relation to COVID, and we do need to keep it as a real live situation for us. I specifically do want to thank you, Jim, for the work that you've led regionally in relation to the pandemic plan. When we participated in the exercise Pegasus work, the draft Northumberland plan was what we took to the table that other areas utilised as that draft plan. So when that comes through to fruition, I feel as assured as we can, based on it will always be a new situation that emerges, but I feel that we have as a robust a plan as possible that can lead us into whatever circumstances we would find ourselves in. So that's a huge piece of work during 2025. And finally, the part that you mentioned around the severe weather and the drought aspect, as you say, we tend to think a lot about flooding, but drought impacts not only the environment and humans, but animal health as well. And for us in Northumberland, that's our food production system. So, and then that's also our economy for farmers. So it's an incredibly important piece of work for us to consider in 2026. So thank you.
Thanks, Jill. In the absence of any other comments, therefore, I'm just going to propose that we agree the recommendations and move on. Is that okay? Thank you very much. Thanks, Jim. So next on the agenda is item 5, Northumberland Tobacco Control Partnership Annual Update. And this is Kerry Lynch going to come and talk to us about this. Hi, Kerry. Again, Eve Chicken would have introduced, but we're just going to carry on with you, Kerry.
Okay. Thanks, everyone. Yes, I'm Kerry Lynch, Senior Public Health Manager in Jim and Jill's team. I can't believe it's another year that has gone by. Here we are again. So yes, thank you for the time again for the annual update. Does this move it on? Press down, and then press again. Right. Okay, so yeah, hopefully you've had a chance to have a look at the report. As ever, it seeks to give you enough information as a board for assurance of the work that we've been doing over the last year, and also to ask you for your authority to continue with the focus and the local action. But I'll come back to those in a second. What I try to do each year, if you had it in you, I think you could read each report in turn, and it will add to the picture. Obviously, I will revisit, and I will in a second, the progress that we're making towards reducing smoking prevalence in Northumberland, and we track that. But also what I hope to do is give a different flavour each time. This year, what I'm focusing on is the strategic themes. Again, if you've had time to have a look at them, you'll see that there are 8 key strands of work that we focus the tobacco control work on. And again, you know, a repeated message from me is that we have to do the work on all of those strands. We can't do one and not the other if we're going to make and we are making a difference to tobacco consumption in the county. We've worked like this for many years. And hopefully, like I say, we've started to see the fruits of that. But as ever, my message is the same, is that we've still got a lot of work to do. Okay. So, like I've said, we always, press it again, revisit this graph. Smoking remains the biggest preventable cause of death and illness in Northumberland and is still the leading driver of local health inequalities. And those greatest harms fall on our poorest and most vulnerable individuals. And that is a message that I repeat every year, and I will continue to do so until it's no longer the case. We're making really good progress, as we talked last year as well, where I showed you a much more kind of longer look back. This, and I explain this in the report, the national estimates, and these are just estimates, have been slightly refreshed, and it actually is showing us an uptick this year in our smoking prevalence, from 7.7 last year to 8% this year. It's really excellent progress. Like I say, I talked about that last time, how far we've come in a relatively short period of time. And it also means that we are pretty close to our local ambition and our regional declaration for a smoke-free future, around 5% or less. So we really are making excellent progress. And let's hang on to that, because then the next slide I'm going to show you what that still means for us. So yeah, I think it's important now for us to really start to think about who is that Northumberland 8%, and not to, again, pick up, Jill's already said about we can't be complacent. That's the same as everything I'm sure that we'll be talking about today, about what that 8% really means. You know, we can look at our population in a geography of our size, in a population of our type. We're talking about 22,000 residents. And I know that if we know that something is harming 22,000 residents, we want to continue to do something about it. These are people who are living complex lives. So these are our residents who already have difficult health situations, financial situations. They're living in social housing, you know, with mental illness. These are residents who likely started smoking when they were children. So it just goes so far beyond choice. Now, I can't even write the word lifestyle next to choice on the slide anymore, because it completely misses the point in terms of really the lives that people are leading. Like I say, started smoking when they were children, smoking now because of you know, because it's a lethal addiction, and then, you know, combined with all of those complexities that they're living with. We can estimate that there are over 19,000 children still living in a smoking household. So I just thought that was important today, because I think 8%, it's great to talk about the progress towards that percent. But when we really still start to look at who that means, we're more likely to see smokers now who are younger, kind of that 25 to 34-year-old age group. You're more likely to be a smoker if you're unemployed. You're more likely to be a smoker if you don't have any qualifications. So like I say, let's think about 22,000 people now, alongside that 8%. What I've got on the last box is costs. Again, what we're always asked for in these reports is to give an idea of financial investment. You can see that in the template at the end, certainly from a council point of view, how much we invest in this work. This year that I'm talking about in 2025, we've spent approximately, you know, heading up to £800,000 on tobacco and stop smoking. But look at the costs that we're trying to influence here, and this is annual. These are estimated annual costs to us, obviously to the individual, but also to us as a system. So smokers cost in terms of hospital admissions and primary care services. They're more likely to need social care, and they're more likely to need it 10 years sooner than a non-smoker. Think about those costs. Costs in terms of fire. I'm just looking at the people in the room. So we need to kind of really focus on continuing with the work with the 22,000. I'm not going to talk too much about the national picture, but enough to say that there is a little bit of detail in the report, but also just to ask you as a board and as key influencers We need to make sure that we do all we can, all the levers that we have to see the progression of the tobacco and vapes bill. It's not a comprehensive tobacco plan, but it will focus particularly around the young people's access to tobacco and vapes, so that children, I wrote this in 2025, but children turning 17 this year or younger will never be legally sold tobacco, which is absolutely groundbreaking. So, like I say, not to focus on it today, but please, we will be doing some work around supporting the progression of that bill. I wanted to mention as well the additional grant that we receive in the local authority. It's ring-fenced for stop smoking services. We're in 2025 was the second year, and some of the examples I gave are funded from that. I didn't know at the time of writing this report, but we do now, that grant is confirmed for another 3 years and will be absorbed into the core public health grant, but still ring-fenced for this work. So, for the next 10 minutes, Chair, I wanted to kind of bring some life to the report. You've got the report, it's 17 pages long, but it's all good stuff. You can read it. Please, if you haven't read it yet, read it, ask me any questions about it. But I wanted to bring some colour and flavour to all of that information that's in the report. Even the report doesn't cover everything, but it's just nice to give a little bit of flavour. So I'm going to pull out some of the strands. Like I said, I focused the report this year on the eight key strategic strands, some around media and comms, helping smokers to stop, a focus on reducing illicit trade, and then an example of a multi-strand piece of work that we've done this year. So media and comms, this is a piece of work that we did, helped with Claire Malone, she's in the room, and Nicola, where some local work that we'd commissioned via Fresh, and again, you'll notice through the report that I mentioned Fresh a lot this year in terms of the commissioned work that they do on our behalf. They did some smoker segmentation work to try and find out more about who our smokers are, and also we'd done a health equity audit in the Stop Smoking service, and both of those pieces of work highlighted to us that the younger smokers, and we're more likely to see them at the moment, don't access support to quit. They're not coming forward for support. So we employed a creative agency to come up with these images. These are, young adults, particularly young men under 35. They're not seeing the harmful effects of tobacco yet. They're still active. They've got young families. We thought these images were particularly, would resonate for those people living in Northumberland. The aim for this was to put the idea of quitting in front of an audience that just doesn't see it. They don't see it. And it used a digital technology called Bliss that precisely targets audiences without relying on personal data. I'm reading from a piece of paper now because this is all tech, that's just fantastic what we can do now. Pause screen advertising on various channels, ITVX, Channel 4, audio streaming on podcasts, etc. Fabulous stuff. If you didn't see these images, it's likely that you're not a male under 35. That's all I'm saying. So it's nice for you to see them here. And we were really pleased that just put the quitting as a positive thing in front of an audience that wouldn't normally see it. And we'll be building on that work in 2026. To continue with media and comms, but also bleeding into Strand 5, which is helping smokers to quit, Fresh are commissioned to keep a profile of media and comms activity around tobacco and stop smoking. And the most powerful thing that we can do is to hear from real people. It's the best thing that we can do in terms of comms. And we were delighted in 2025 to be able to put forward Ian from Wylam, actually helped to quit smoking with Mark's help over there. Ian had smoked for 50 years and quit in March of last year, and he has suffered from health complications himself, which he talks about in a minute. I'm going to hope that the tech works. It didn't work last year, but that's why I've got that slide. But let's see if we can hear from Ian himself. Let's see, I'll go on to the next slide, and then I don't know if you can press the play bit.
My name is Ian Slother. I'm 67 years of age, and I live in a beautiful little place called Wylam on the Tyne Valley. I did actually stop smoking when I had an accident which resulted in amputation of my lower right leg. That was 18 years ago. I came out of hospital, and with my sister being a smoker, I started smoking again. and I had my last cigarette after my breakfast on Sunday the 30th of March. Well, I'm just starting to feel the benefits now health-wise, so another 4 or 5 years down the line, probably even better still.
Back on media and comms, it's just really, really powerful and wonderful to hear, and really inspiring that Ian has given up smoking and will inspire others to do so, definitely. Thanks for the tech work this year. Okay. Staying with helping smokers to stop, this is an example from Northumbria Healthcare. Northumbria Healthcare has embedded a Best Start in Life pathway to ensure all pregnant smokers are identified at booking and supported continuously until 12 weeks post-delivery. They receive tailored support from a named advisor, and you can see the comment on the screen from this lady of how important that support was from someone that she built a relationship with. They receive, same as our service as well, nicotine replacement therapy, licensed vapes, incentive vouchers, all in line with NHS recommendations. And the smoking at time of delivery rate, again, I've explained this in the report, it depends on whether we look at national estimates or local data. It's about 6%, which is a fantastic place to be in terms of helping pregnant women quit. Pregnant women to help to quit has always been a challenge. If pregnancy is going to be a motivator for you to quit, then you quit. So what we are then working with is ladies who find that very difficult. So to get that smoking at time of delivery rate to 6% is fantastic progress, and thanks to the Trust and the work they're doing on that. Okay, and then just moving to strand 6, which is the particular sort of focus here around illicit trade. I like to talk about trading standards. It's kind of a really different piece of work that is very, very important when we look at those key strategic strands. The images that you're seeing on the screen now are as a result of work that Trading Standards did in terms of handling intelligence that they got and using that to identify and dismantle an organised crime group that was working in East Northumberland, supplying large amounts of illicit tobacco to our communities. They located and gained access to a container where at the back of it they found over 1,000 pouches of tobacco wrapped in black bin bags, ready to be distributed illegally into our communities, with a retail value of over £47,000. We fund a post in Trading Standards from the Public Health Grant, and will continue to do so. Lots more detail in the report, but like I say, really, really important part of our strategy. Whilst we know that actually price is a real driver to help people decide to quit smoking, we try to do work in communities, but if this is on the doorsteps, and it kind of literally is, at cheaper price, it just undermines all the rest of the policies. And so, fantastic work. And then finally, I'm going to, and I did ask if anybody could come from Sorted today, but they couldn't attend today, unfortunately. This is an example of some work, and again, I know we've got Abby in the room, and we mention children each year, and hopefully, again, Abby, you'll see some progress again from last year. So I'm reporting today on an embedded worker that we've got in Sorted now. Sorted is our young person substance misuse service in Northumberland. Who are using their model, and they've got a kind of multi-strand model themselves that you can see on the screen, to support children who are addicted to nicotine. So this is children who are smoking but vaping problematically as well, and I talk in the report about it's important that we separate problematic vaping with children from the vaping offer that we want to give adults who are smoking. We know that if you continue to smoke, it's uniquely lethal. So for an adult who is smoking, switching to a vape is a positive alternative. But we don't want to see our children vaping. We don't want to see them addicted to nicotine. So this work is starting to address that and look at that. And the example that Miriam has given me, Miriam in Sorted, was a referral that she got from a school nurse. And as a result of this, she's working on a one-to-one with this child who was having difficulties at school, behavioural difficulties, attendance difficulties. And as a result of working with Miriam, they have reduced their vaping consistently. They've started up some physical activity that they'd stopped doing because they were vaping all the time and they were having difficulty with doing it. So they've started that up again. They're not vaping in school anymore, having previously been vaping throughout the day, in the toilets, during lessons. They're in lessons more constantly. Their attendance has increased. They're not getting into trouble with staff now for their vaping all the time, so those relationships improving. Again, in the report, you'll see a little bit more detail about numbers and outcomes that we're starting to see from this work. But hot off the press from this week, Craig tells me that Miriam is working to capacity now. She's seeing 23 children for their nicotine addiction, and this was a real gap that was falling between services, so it's really exciting to see that progress. So, in summary, adult smoking prevalence is at the lowest recorded since records began. Fantastic, it's amazing progress. But like I wanted to focus today, for us in Northumberland, we've still got thousands of adult smoking, and we still want to make sure that we're supporting children not to smoke at all, and to support the small number, but the important number that are starting to vape. This year, what the partnership would like to focus on is more looking at data and really sort of working as partners to collate that picture. So, you know, what I'd really value from you is your authority to your officers to participate in that and bring that data picture together. Naturally, we want to keep an eye on children and vaping, but I don't want you to kind of take your eye off tobacco smoking, which we know is the absolute priority, but naturally we will want to keep working with partners around children and vaping. And like I've said, there will be some work around the tobacco and vapes bill that we'll need to continue to push through to make sure that comes to fruition. Recommendations are same as James, really, to please note that the development from 2025, please offer some guidance and comment for 2026's emphasis and authorise us to proceed. Thank you.
Thank you, Kerry. I'm pleased you've done the formal bit about what we're actually expected to do here, but I was going to do that anyway. I'll come to questions in a second. Okay. Chloe's in the room. From a mental health perspective, one of my thoughts is that a lot of our young people, especially in the vaping environment, are probably self-medicating and often have other mental health problems and may be known to SIPs. And I just wondered where the liaison was between Children's Young Persons Services, because they're a cohort I think would be ripe for targeting, perhaps. And then a slightly more light topic. Obviously, for the majority of men in the room, we did see the promo for the under 35s.
Mm-hmm.
Yeah,
of course.
Okay, thank you. Over to you, Abby.
Yeah, I mean, I welcome everything that you said in that report, and I know that you know, just to recognise the work that you're doing here. I really welcome that focus on the 22,000 people rather than percentages, because I think that helps to really bring that home to people in terms of the numbers. And also, I mean, great work with the trust in terms of that maternity rate. The children still does still worry me, along what you were saying there around sort of nicotine. We're aware of children who are using nicotine substitutes in order to get that high. So it's not just vaping, and actually what we're certainly seeing, both with my own children, but also that we're seeing sort of across our services and things, is vaping is a gateway. It's now being recognised as a gateway for children to smoking, and we're seeing a big increase in the number of children who are physically smoking again. You know, and that's a real worry. So I think that stuff you're doing with Sorted is amazing, and I really look forward to seeing how that plays out in terms of trying to change that trend. I think it's about that experimental thing is going up, isn't it, with young people, even more of them. I think there's been a big jump from 24 to 25. Yeah, and thanks, Abby. And I know it's always nice to see you in the room, because you know you support the work, but it's important because it keeps us going, and we know that you know we're doing the right thing and helping with that. Yeah, I mean, I think certainly conversations that we've been having, Jim and Jill, is that vaping is different. It's sitting here with tobacco at the moment. But it could equally and easily sit with the drug and alcohol and substance
work that we're doing. What's useful is that both of us, and myself and my colleague John Liddell, work with Jim, so we need to kind of see where it sits. So for now, we'll report on it, but it might be that we'll start to see whether it also needs to sit and be addressed in that drug and alcohol arena as well. Children, I don't think, see vaping in any way related to smoking. It's a separate issue. They start vaping as a substance to try, as something to do. So I think that's why it's really great that it's sitting with Sorted at the moment, because their expertise in working with children who are using substances kind of will absolutely work with this particular mechanism. But yeah, we don't want children to continue, to start to smoke where they wouldn't before. I've said this before, I think, as well. These are the children that probably would be smoking and maybe vaping as well. It doesn't matter. It's not what we want to see, but I completely agree.
Thanks, Kerry. Chloe?
Thanks. I think from a CNTW perspective, I think we do a lot of work with our hospital sites, particularly where smoke-free sites, smoke-free wards, and we have a captive target audience that we can support hopefully during their stay with us, and then hopefully that will continue into the community. But I do wonder if there is a gap around our children, young people's joint up working with yourselves and Sorted, and I'm happy to pick up a conversation outside of here to make sure we've got the right people involved in that. I think there's ideal opportunity for our staff to be doing more at that early stage and that preventative. So if we aren't around the table, more than happy to look at how we can do that better.
Really helpful, thank you.
Thanks, Chloe. Deborah, just from a fire and rescue service perspective, is there anything that resonates with you in this? Or I'm just thinking about fire risk and any experiences you've had of late from a prevention point of view.
Absolutely. Smoking still very much correlates with fire in the home and some of the inequalities that are associated with that. Just doing a piece of work at the moment around our community risk management plan, which is out for consultation. So very much the shared data is really helpful, and the shared intelligence down to individual level really helps to direct the work, and the partnership visits of homes is really helpful in that respect to reduce the numbers. And we're just monitoring those dwelling fires at the moment in terms of slight increases of late, but smoking is absolutely still one of the biggest factors for us, alongside other health inequalities as well.
And fire and rescue completely use a MEC approach. I think we've talked about that in previous years, and Deb and I and colleagues have talked about that. So that's embedded in fire and rescue, isn't it, around that kind of MEC approach around smoking and referrals to the Stop Smoking Service.
Thank you. I completely echo Abby's point around that 22,000, because it does bring it to home. And we talked about that last year, didn't we? Because as you get to the lower percentages, people do get complacent and think, well, job done, or that's just your natural background level of smokers. But the other stat that was in your slides is the 19,000 children living in a household with smokers. So I do think that's the other stat that we need to take away and think about. I'm looking, obviously, Vicky, at yourself from a family host perspective, Rachel from a 0 to 19 perspective. Are we great news around the smoking at time of delivery shift, but what are we doing with children who are in those households? So I think when we're talking about and exploring what our next emphasis is, that conversation also around shifting more towards thinking about addiction of nicotine and that interplay with drug and alcohol. And then the final bit for me for consideration is the scale of Sorted. It is one worker at the minute, and that capacity building opportunity that we may well have with our education colleagues, with our family hubs colleagues. So something to explore there, perhaps more around that capacity build. And thank you as always, because an annual report sometimes can be, oh, we've heard this before, and you always bring a fresh slant to it. So everyone needs a Kerry in their team, but also the team that are in the gallery as well, Nicola and Mark and Claire, because it wouldn't happen without you guys. So thank you.
Thank you.
Rob?
I have a question, and firstly, thanks for the presentation. It's both reassuring and worrying in equal measures. Normally, when you're looking at behavioural change, there's a big law of diminishing returns as you get into what I call the hardcore issue. However, what you're saying is, though, that the 8% isn't made up like by sort of, what I would call the perpetually smoking cohort. There's lots of young people in there as well. So I was saying that the approaches that have got us to 8% will be exactly the same approaches that we'll use to get into the 8% and reduce that.
That's a hard question for a Thursday morning. I think yes, and also we need to watch it. So yeah, I mean the strategic approach to tobacco control is very well evidenced. But you're absolutely right. As we get more and more of that 22,000 reduced to 12,000, and we really are looking at people with severe mental illness and severe addiction, then yeah, I think we might have to put different emphasis on different elements of that strategy. I completely take your point. Really good point. Yeah.
Thank you. Are we all done? I'm seeing nods. Thanks for a really interesting presentation again. It's always really interesting to have you here each year, Kerry. Let's hope the next year doesn't go quite so fast. So we have listened, given comment, and now we are assured for you to proceed with your plan. Thank you very much. Okay, breathe for a second, relax. You've done an hour. We'll do a handover. So the next on the agenda is Anne, and she's coming to talk about the health impact assessment update. So, hi Anne, do you want to get your slides sorted? And we'll just relax for a moment.
Hi everybody, Anne Lawson, Public Health Manager, responsible for tackling inequalities through housing and planning. I'm going to just give you an update today on health impact assessments and how we've been using them with the planning team over the last couple of years. Yeah, so yeah, we've been looking at health impact assessments since June 2023. So this is not an annual report. This is a catch-up since then. As you all know, built environment affects health both directly and indirectly, and many elements can all contribute to our residents' health. Big long list: air quality, noise, housing quality, access to green spaces, street design. The list goes on. Lots and lots of things have an impact on people's health in our environment. So this gives us an opportunity to comment on things as new plans come to play. So the Northumberland Local Plan was adopted in March 2022. Lots of work from Rob's team and from Jim in making sure that health impacts are required on major planning applications through the local plan. So major planning applications, which are the larger ones, either have to submit a healthy planning checklist or a rapid health impact assessment or a full health impact assessment, and I'll talk to you about the different demarcations of those in a minute. When health impact assessments come through to the planning team, we, and Cam's here today, does a lot of the work on this, as a team of NCC officers led by ourselves in public health, we review those health impact assessments and give feedback to the applicants as part of the planning process. So a health impact assessment should identify both positive potential outputs from a scheme and negative potential impacts of the development process. And what we're looking for in all of that is to maximise those positive health impacts and to minimise the negative impacts, and think about what the mitigations that might be for those things. And to quote Rob, on several occasions has said what we want to see in Northumberland is that all new developments bring a positive impact on health rather than only looking at the potential negative. So we're looking for things that bring additional benefits for our residents. So I'm going to go to my next slide, apologies. Having a slide nightmare. So, in terms of the demarcations, major planning applications come in, all of them are required to do a healthy planning checklist. That's just a checklist that makes them go through a list of different criteria that could have an impact on health and just say, have you thought about this? Have you thought about this? Have you thought about this? For most schemes, for all schemes, people have to check through that list. We have a review of those. Cam has a look at all of those that come in, and we just do a little double check to make sure that we don't want to request a health impact assessment that goes into more detail around mitigations. However, those schemes which are over 100 dwellings or over 10,000 square metres of commercial development space have to put in a rapid health impact assessment. That requires a look at all of the different elements that might impact health, and to really, for the developer to really think about what the impacts might be. And what we're really hoping for is that they will take action on those things and to define their scheme based on what they've thought. If a scheme is over 400 dwellings or over 40,000 metres of square commercial floor space, then we need them to do a full health impact assessment. That takes a long time. Requires a full scoping. It requires lots of community engagement. We expect them to take between 3 and 6 months to do that. It's a full deep dive into what the health impacts of that scheme might be on the community in which it's placed, and requires them to actually understand the community around the site in which they're working. We do have a clause in the local plan that allows us, if we believe we've looked at healthy planning checklist and they don't quite meet some of those criteria, we can actually just go back and say, actually, this scheme is particularly important, and we can see that the health impact assessment might be useful here. What we really want them to do is to do that health impact assessment early in the design process of the scheme, and not as a thing that they do at the end, because they go down the planning list and go, oh, I need to do this. What we're trying to encourage people to do is to do that early in the process. So far, this is just a little table of the ones that we've looked at to date over the financial years that we've been looking at them. And you can see that actually until the end of last year, which is when this report was written, we've only actually reviewed one full health impact assessment, and that was for the QTS scheme in Camas in Blythe. We've now had another couple that we've required. So the number of applications reviewed has gone up, because we're now looking at all of the healthy planning checklists, because we want to make sure, and in terms of NCC schemes, we like to see that our schemes do think about health impact assessments, because we want to be exemplary in the work that we do here. When we go back with our feedback from a public health perspective, we go back in terms of several different ways. We can either give advisories, which is we do a full sort of appraisal of the health impact assessment. We give a lot of feedback, and we can either go back with an advisory saying we suggest that you do this, and to improve your scheme from a health perspective, we might encourage you to do this, or we will give to the planner in development management some proposed conditions that say we require you specifically to do this before planning application can be done. Or in some really small number of cases, we will put an objection in if we feel that there's a real negative impact on health, and that the developer isn't engaging at all in trying to do something about that. For all schemes, we have online written guidance, which we're constantly reviewing and updating, so that anybody requiring to submit an HIA can get some guidance online, but also there are contact details, so that we do encourage them to get in touch with us if they want support early in the development, so that we're there to help them to do that. So just a few of the recommendations that we've given to date in terms of feedback on health impact assessments, to give you a sort of a flavour of the things that we are commenting on. So we've requested an improved active travel plan and a supply of better quality information around bicycle storage, one scheme. On another scheme, we've asked them to provide on-site defibrillators. We regularly ask for exploration around local employment opportunities. If we're looking at housing schemes, we encourage people to put the affordable housing throughout a scheme, rather than just tucked away in the corner as a little separate area. We don't want segregation. We want communities to feel engaged and together. We've looked at we've given feedback on requiring increased walking and cycling opportunities within a scheme, improving access to a community garden, and a requirement for a healthy workplace strategy and a community engagement strategy around one of our very largest schemes that we did, and we're continuing to work with that provider post-planning approval on delivery of those things. We've also asked for provision of active travel corridors from a housing estate to the local town centre, where that wasn't provided. So we have a local plan which was adopted in March of 2022, and that does give us a good opportunity to comment on health and it does have some policies in there which are linked to health. We have a specific health policy and several other policies which support a health agenda. We are in the process of reviewing that local plan, and as part of that, with the health team, we're going to be looking at first of all, reviewing the impact that the current local plan has. We're working with the Town and Country Planning Association on that. And we're also looking at bringing in someone to support us with doing a health impact assessment on the local plan. And we're thinking about a participative approach to all of that so that we get a variety of different stakeholders involved in reviewing where we're at as part of the development of the spatial strategy. What we would really like to do is to suggest that we have a closed session of the Health and Wellbeing Board as part of that process so that we can sort of present to you the findings of what we've discovered around the existing local plan, and also where we might be heading as the local plan changes in the next couple of years. So that would be my recommendation and request of the board that you get involved, please. Yeah, so there's my recommendation. So a closed session is what I would like. And I think that's my last slide. Thank you.
Thank you very much, Anne. That was quicker than I expected it to be.
Rattle through it.
I knew Rob would have something to say, so I shall come to Rob in a minute. Thank you, Rob. So it's interesting, isn't it? Because when we hear about a formal process and a local plan, it feels very dry. But when I think about all the work that we have done coming from the inequalities work and now through to the Northumberland Partnership work and the work that we did around accommodation and living and the building blocks of a good life, this kind of feels like now a natural progression to go back to this and say all those principles that we have learned and we are all now aware of as a system, how can we ensure that they get stitched into this and think about strengthening communities and all of that work. So it kind of feels like we're completing a circle here, that we've done all of that background work and now we're going to do something which is more formal in some respects because it has to be done, and yet we'll approach it in a different way, I would hope. Rob?
Yeah, thanks for that. And firstly, thanks for Anne, who's been very, very supportive and effective in this process. And her presentation nailed the key issues. I just want to come up with a few key points. This is about influence, not about auditing schemes. So you mentioned it being dry. It is about being involved early in the process so we can change schemes. Because actually saying no to a scheme is then the final sanction. It's a human nature issue because as architects and designers progress with their schemes, they get naturally more defensive about changes to it. So getting there early is really important. Also, the influence is on both what I call soft and hard changes. Hard changes, I mean design, layout, physical things like cycle paths. Soft changes are issues like very focused support, say, for apprenticeships in nearby communities with particularly low levels of economic activity. To be clear, the hard changes to schemes aren't just about stopping schemes causing harm by say, causing pollution or noise, but it's about really using the opportunity to deliver opportunities for healthy choices. So, the classic one is walking and cycling. Okay. And I'm going to go back as well to when we started off this process, and I think you nailed this as well, in that I remember doing a presentation very early on about inequalities work, saying the trouble is that health in decisions like design of places is traditionally underweighted. In other words, it's regarded as either a tick box or just a nice to have add-on. This mainstreams health thinking in the planning process. To be really clear though, and I see this to have to be able to give the ultimate sanction and us to say no to schemes that do not make a positive impact. We have to be able to, and I've stood in front of public inquiries too many times not to know this, when we say a scheme is going to have a total adverse health impact, we need to be able to demonstrate significant and demonstrable impacts. And that's where this group is really useful in the range of expertise that is here. Finally, part of the quite low number in Anne's table of HIAs that's been done so far is partly attributable to the fact that the reason why we are updating the local plan is effectively because we've got new higher housing targets, but also we have used up many of the sites. So actually, new schemes coming through, major schemes, will increase over the next 2 to 3 years. So getting this right now is really important. Okay, thank you.
Abby.
Thanks, Anne, for your report. I think it's really sensible to have that kind of staged approach and to have that because, you know, what nobody wants to do is just to hold up planning so that there's no progression. So I think that's really important. What I would love to see, and I don't know if this is the plan for the closed session, but it's about when you've given those advisories or those proposed or those guidelines or advice, what's the impact of that? And I think it talks to Rob's point there because that's how we can then build the evidence base to be able to make those objections where there could be deemed to be significant harm or significant benefit for doing it differently. So I think it's just about that detail. So I look forward to seeing that because I think that's when the meat on the bones, if you like. But
Jill?
Yeah.
Oh, sorry, Anne.
You're absolutely right, and we wrestled with that about whether we could put that into this report. And one of the reasons that we gave you a list of the sort of advisories and the conditions that we've put in is because actually schemes take a long time to come to fruition. So we are not, for the majority of schemes that we've reviewed so far, the bigger schemes take a long time to actually come into play. So actually what we're going to do, and Cam's going to do this, is going to start doing some visits to sites and just have a look at them and see once they've actually completed. So you're absolutely, yeah, bring it to life and actually experience, you know, whether they've listened or not. Thank you.
Thanks, Anne, and thanks, Cam, as well for the report. It was a newer topic for us to bring, and we wanted to bring it in a way that was meaningful to the board, and it's so timely in relation to the local plan. In particular, you would think it is, I suppose the obvious ones are that the active travel and the cycling and the walking, but it is also about the healthcare provision. We get a lot of questions and overview and scrutiny about, well, what does this mean for GP practices? What does it mean for dental practices? So having that combined conversation will be really helpful. But I'm just thinking, John, with you in the audience as well, I know previously talking with Sam Rennison before she retired, she was really keen to participate in this from a safe community perspective and a community cohesion perspective. How do we design out disruptive behaviour? How do we design in safe community cohesion and opportunity for integration? So it'll be in particular for me interesting to see that policing perspective coming through into the advice and guidance around health at its biggest perspective. So welcome the development session to take us further, and also the opportunity to have that much more collaborative approach. So thank you.
Anybody else? Any more takers? No? So thank you very much, Anne. I'm taking from the feeling in the room that we would welcome a development session on this. Yeah. Okay, so we'll plan that in. Thank you. Okay, so we are now going to go to item 7, which is the Northumberland Children and Adults Safeguarding Partnership Annual Report. And it did throw me because it was 6 months on an annual report. But the first thing in the report is explain why it's 6 months. So I got it immediately when I saw that. Thank you. I have Neil and then Audrey. So actually now we have Sarah and Emma, I think, coming as deputies. Is that okay? Yes, please, come up.
Okey-doke. Thank you. Yes, the first thing to point out is we aren't Neil and Audrey. However, we've been drafted in last minute to summarise this report. So we just start with a bit of a reminder, as usual, around safeguarding being everybody's responsibility. Northumberland Children and Adult Safeguarding Partnership is the mechanism that drives that within Northumberland. Jill mentioned before about the strength of our partnership work, and again, we would echo that. I think we're well known regionally and nationally for our strength of partnership work. And so locally, there are 3 safeguarding partners who hold an equal statutory duty to establish and maintain robust safeguarding arrangements. So We have lead safeguarding partners for the local authority, that's the Chief Executive. For the Integrated Care Board, it's the Chief Executive, and for the police, it's the Chief Officer. They then have delegated safeguarding partners, which is Audrey and Neil for the local authority. It is the Director of Nursing, Richard, for the ICB, and Chief Superintendent Area Commander Kevin Waring is now the delegated safeguarding partner, having taken over from Sam Remington, who's just recently retired. So there are links throughout these slides and also within the report as well, which give a bit more detail. We have shared the 6 monthly report with you, and hopefully you've had a chance to read it. So the report, it acts as a supplementary report. The reason behind that is we have previously reported September to September. So we published our last report that went up to September 24. So this 6 monthly report covers the 6 months after that. It does explain as well why we're here in January talking about a report that goes up to April 25. In the forward plan, we've always kind of come at this time. Our report would normally be published around November. So it does feel as if we're talking in the past a little bit, and it's hard not to get into what we've done since then, which is we've had a lot of activity. But we will be looking to publish our next report. We'll be working on it in April, so we should hopefully come back to this partnership a bit earlier. So some of the things that we've been doing, obviously we've talked about our safeguarding arrangements and the responsibilities around that. In the children's world, we had an update of our statutory guidance, Working Together to Safeguard Children 2023, and that required us to review again our safeguarding arrangements, our multi-agency safeguarding arrangements, which is how and when we work together as partners across the strategic and operational landscape. We formally published those in December 24, and they're available. Information sharing protocol, so you will likely be aware that information sharing is something that comes up time and time again when we're looking at reviews and reviewing serious incidents, as we're statutorily required to do. In Northumberland, we've got an agreed information sharing protocol for children and adults workforce that sets out legally and statutorily how and when we should be sharing information. The purpose of that protocol is to give practitioners the confidence to be able to share information confidently and ultimately safeguard children and adults. That protocol has now been embedded within multi-agency training, and we continue to do that. We quite regularly review our membership. I've mentioned the 3 lead safeguarding partners. However, our partnership includes all of the agencies that we work with and also schools. The fire service are very involved. The health trusts are all very involved in our partnerships, and we do appreciate them as well. We have actually widened it up a bit more to include a few more representation, and we will continue to do so. So when we combined our partnership from separate children and adults partnerships, we did retain some separate groups. So we recognise that we work to different legislation, and we try and kind of keep a focus on children and adults separately where possible, and then come together where we need to. We did originally have separate business groups. However, we recognise the benefit of those joining up. Some of the members cross between adults and children's, and we just recognise the whole thing family approach, that it really benefited us to join those meetings together. We do have a statutory duty for reviewing serious incidents and having reviews, and we have also, during the time frame of this, reviewed our processes for doing that and our frameworks for doing that. Again, links to those are within the report.
Thanks, Sarah. So although it is a 6-month period, we're pleased to say that we did make a number of key achievements in that time frame. The previous annual report gave an overview of the Sophia Local Child Safeguarding Practice Review that we had published, and in this 6-month period was when we really went out and shared the learning with frontline practitioners, that we'd established the recommendations and the things that we needed to change and strengthen throughout the review, and we were really successful in reaching over 300 practitioners across all of the different agencies that work with us in the safeguarding arena. We had some really positive feedback throughout those sessions, and part of that was then following up with some shame awareness trainings. That was part of the learning that came out of that review. In terms of exploitation and missing, we launched our partnership reduction of exploitation and missing. That's led by the police at that time, and there were some road shows across the region to make sure that all of our frontline practitioners understand sort of what the arrangements were for that and how we go about doing that piece of work. And that's been really successful in reducing our number of missing episodes. So there's some stats on there for you in terms of that. So 13% fewer missing adults, 16% fewer missing children, and that uptake of those return to home interviews that we do for the children's side of the business really improved throughout that period as well, which was really positive. We've had a number of policy updates. So on the children's side, our thresholds were updated and shared across our workforce. On the adult side, we relaunched our self-neglect guidance, and that was done across the North of Tyne, so with our colleagues from Newcastle and North Tyneside. As Sarah's mentioned, our local child safeguarding practice review and safeguarding adult review frameworks were updated, but we aligned those in that period to make sure that regardless of whether we're looking at an adult or a young person, the processes are effectively really similar, and from a practitioner point of view, we're really clear about what needs to be done, when you should submit a referral, what those referral processes are, and then how we go through that review process, just to make it really clear for all of the agencies that we're working with. And information sharing guidance, as Sarah mentioned, was updated as well. We've made some real strides in this period on collating our data. So we introduced some interactive dashboards. We have a joint performance management subgroup from the partnership. So that covers children's and adults, and it really allows us to reflect across that whole family approach to make sure that we are picking up on any trends or concerns, and then we're feeding that into our other groups within the partnership as well. That included some improved disability coding and accuracy, and we had some feedback in that period as well from Ofsted around our quality assurance arrangements, and those arrangements are reflected across at the adult side of the partnership as well. We had some targeted work around domestic abuse and young people and older people, so we had task and finish groups around both of those areas of work. And you will see a lot more in the next annual report that we will bring to you around those pieces of work, because they've really developed since this annual or this 6-month report was published. So a lot more around our teenage relationship harm pilot, and then also from the older people point of view, we've done some work across with our colleagues in North Tyneside, and that also involved our colleagues in the Safer Communities team as well, because it crosses over with some of the work of the Safer Northumberland Partnership around domestic abuse, as well as the Domestic Abuse Local Partnership Board as well. Safer in Education, we have a subgroup for Safer in Education, and they've done a lot of work around elective home education. The strategy was reviewed and strengthened, and we also introduced a local definition for educational neglect. That was agreed with all the partners, and then protocols were updated following on from that piece of work as well. So lots of work around elective home education. Thanks, Sarah. Obviously, we also have challenges in the period, and identified some emerging risks as well that we wanted to focus on going forward. So recruitment and restructuring, there's often pressures in terms of staffing in safeguarding teams, and obviously we know from our colleagues in the ICB some of the challenges that they're facing, or started to face a bit in this period, and that's ongoing at the moment in terms of their role within the partnership, but we work together to make sure we mitigate any sort of risks around that, and obviously work together across the different agencies to support each other.
Yeah, we've also got the national reforms within children's as well, which you'll likely be aware of, and that's obviously been progressing since this report and continues since.
Thanks, Sarah. We also did a piece of work around face-to-face child protection conferences. So we know that families do prefer to meet in person, but obviously the geography of Northumberland, often that's a challenge. But we put some guidance and had a lot of discussions around that to make sure that we're implementing our approach consistently across the county. The elective home education work was a challenge as well. We did identify some safeguarding gaps within that. Obviously, we're waiting for national reform information, but we have to develop our work locally as well. You know, we can't wait necessarily for what's going on nationally if we're identifying a concern that we've got in Northumberland. So we did a lot of work to understand what the prevalence was, what our safeguarding arrangements needed to be, and we have made a lot of progress on that. So again, it's something that you'll see a lot more detail on the next report.
And just to have included a link there was some regional work around that. And just as a bit of a reassurance, in Northumberland, it's noted that we, within the confines of we're allowed to, legally and statutorily, we do have a good offer for children who are electively home educated. We recognise that not every child who is electively home educated is abused, but however, we do recognise the extra vulnerability and the additional vulnerability for those children who statutorily don't have a right to be seen by any person, and it's been a concern of ours as a partnership for years, and we're just still awaiting the national reforms. However, within Northumberland, we do what we can within the confines that we're allowed. That phase 1 report there was led by the independent scrutineer and includes the arrangements across our region, what we each do in each of our 6 areas, and how we can then improve to strengthen numbers, work together.
Complex mental health is one of our strategic priorities. Our current priorities run from 2023 to 2026, so we are about to look at those again from April forwards for the next 3-year period. But initially we did have a little bit of delay in the task group work around this area. But we identified a need to align that work. Obviously, we know that our colleagues in public health do a lot of work, and our colleagues in the mental health trust as well. So it was just about aligning the different work, the different partnerships and agencies to make sure that we're just not duplicating any work, but also identifying any gaps and where there's issues around safeguarding that we are filling those gaps. In terms of emerging risks in this period, we did identify some trends around exploitation concerns. So I know we've heard today around the health issues with vaping, but we were very much looking at vaping as a tool of exploitation. That again was identified alongside our colleagues in Safer Communities and the Safe Northumberland Partnership through our exploitation subgroup, which is a joint piece of work really with our colleagues in community safety.
So yeah, sorry, just to add to that, because we did mention it, and Miriam had a mention earlier around the work with sorted and vaping, and we're very much linked in with that. We know that it's an emerging trend that vaping is being used as part of exploitation, not just that it's being used as part of grooming, but also about a way to transport drugs, and young people have been shown how to use vapes in order to secrete and transport drugs as well. So another example I think of partnership work, and I know Miriam's been doing a bit of work with our school safeguarding team and also linking in with the schools as well, just to make sure that the awareness is raised too.
The report also includes a financial overview, just to make sure we are being transparent about where the money for the partnership comes from and what we're spending it on. Our income is from contributions from the local authority, the police and the ICB, and obviously we report back through the executive group around what we're spending our funding on. Majority of the funding is in relation to staffing costs, but obviously when we have statutory reviews, for instance, we have to employ independent authors, so that can be the area where we're not really sure year to year how much we're going to need to spend, dependence on how many reviews that we need to do. But there has been, since this period, some regional work around exploring a more equitable cost-sharing arrangement across safeguarding partnerships, and again, it's something that will be a bit more detail on in the next report around that.
So just some key points around looking forward. So we have had 3 key priority areas for the last 3 years. Emma alluded to the fact that they're coming to an end, and we will be reviewing those again. So any input that anyone will have around those is very welcome. We do that again in a partnership way, and we invite other people. We obviously try and take note of other partnerships, priority areas, so that we're not duplicating, but we're working together. On top of the 3 priority areas, we also every year agree some additional areas of focus, and we've agreed those for, and we've been working towards those for this year, and it will be moving into next year as well. Some of that is around data indicators, so measuring impact, the so what. You know, data is interesting, but what difference are we actually making? We've noted that we've done a lot of work previously around transitional safeguarding. Our transitional safeguarding protocol was highlighted nationally as an area of good practice, but we don't want to get complacent with that. We want to think about what's happened now, how, you know, what difference is that making? Is it still part of our day-to-day business? We know that there are safeguarding issues for carers and young carers too, so that's an area of focus for us. Someone mentioned previously around the prevalence of homelessness and rough sleeping. We did get a ministerial letter around that, so that's something that we're going to be looking at across our partnerships too. As Emma's mentioned previously, we're looking to continue to strengthen our arrangements for elective home education and respond to those legislative changes. And we're also, as part of following on from a national review, we're developing a local plan for our response to child sexual abuse within families too. And that's a quick whistle-stop tour.
Thank you very much. I'll open it up for questions in a minute. Just as a GP, I guess, working on the sharp end, this just feels, it resonates at many levels with me. So in my daily work, there's hardly a day goes by when we don't have some kind of discussion in the practice about some safeguarding issue in our morning MDT meeting. In Northumberland, our ageing population means that a lot of our discussions around vulnerable adults, often those that live alone at home, so having really close relationships on the ground with adult social care and be able to sort of know our patients and know that somebody else knows them and have a face-to-face discussion before anything actually occurs and say, we've got some concerns here. So it's that low-level stuff that often avoids escalation. Also, however, we have more and more of our older adults in care homes, and their relatives are at some distance from them, and often that anxiety about giving the responsibility of care to somebody else. And I'm very aware of safeguarding issues to do with people who are living in care homes, so that's another area where I think there's a lot of work involved. Some of our vulnerable younger people are also in care establishments, and that can sometimes be really difficult to understand what actually is this care arrangement, how safe is this person in this care home establishment, so that can be another difficult area. And the one about the home education is, we've had discussions in this forum before with the children's and young persons and discussed how disjointed some of the services sometimes can appear to families. And it, for me, is a real red flag when I get somebody who they've elected that the support in school, or they cannot get their child to school, and that child is now being cared for at home. And who has the daily eyes on that situation? And as a GP, I can often feel quite vulnerable in that situation because it's not quite clear for me who does from the other agencies have that eye on the well-being of that child. Yeah. So there's so many layers in this. And it all comes down to relationships between agencies, so therefore it's everybody's business. And the more that we know that the people in the agencies in the partnership above have functional relationships, the more those functional relationships get passed down the chain. Because often I think there can be, safeguarding is really hard, and in your daily life it really can be difficult to work through some of the issues because you really want to get the right answer, but you know that sometimes implementing a safeguarding process can have a real impact on a family as well. And therefore having the confidence to talk to other people who have knowledge and know who to talk to. So the permissions from higher up the organisations to say you need to speak over here and have a relationship and have forums where you meet, I think is essential in this. Because sometimes it can be, oh, I've passed that to that agency now. I can relax, it's not my responsibility. I've told safeguarding. And I think that's a really tricky situation to be in if the system works like that. So it's just making sure that we all have that shared responsibility. So thank you very much. I'll open it up to anybody else who has any comments.
Thank you, Chair. Regarding the elective home education, do we have like attendance or welfare officers making monthly or quarterly video or home inspections to check that there's no educational neglect or other neglect going on?
So they are limited, the duties are limited, and I think it's around that access to appropriate and suitable education. So we do have education welfare officers and attendance officers. I'm not sure that they do regularly, go into the home and see the children. They do have to be assured that the education is appropriate. It's not about following a usual curriculum, but it is about it being appropriate. However, the workers within those teams are aware of the additional vulnerability, so they know that if there are concerns around safeguarding, to report that in appropriately. The frustration is that there is no duty to have to see the child within those processes. But there is, the team do a good job in building those relationships with families, and the majority of families don't have nefarious intentions who are home educating their children. The report that I referred to is, gives a bit more information about the reasons that people home educate. It's not just to keep them withheld from services, so within the confines that they're allowed, they do work with the families and see the children where they can. And obviously, if there were normal attendance issues, then that would be picked up through the normal procedures as well. Can get you a bit more information if you need it on it, but...
It was just for the, you were saying in the report that because the children aren't going to school on a daily basis, where I know that teachers would be able to pick up signs of change of behaviour and what have you, and then go and signpost them to other agencies. I just feel there's a gap there for home educated children not to be checked regularly, and I think it should be something that we should be looking at to have. I know it's not in the remit at the moment, but I think it should be something that common sense and decency would say we should have some sort of interaction. Yeah,
and I think, again, it's around those people who are going into those homes being aware that there's the extra vulnerability. So I know we've done work with the fire service and the police. So if a police officer goes into a house and sees children, they'll think, well, they're seen by school, and we're not worried about them as much because they're probably seen by school. However, if they know to ask whether they're home educated, that'll then say, actually, there's an extra added vulnerability here that we need to be aware of. So it's about, raising awareness with anybody who goes into the homes, not just kind of education workers or social workers, and it's about that early intervention, isn't it, as well?
Jill?
I just wanted to trailer Rachel in, actually, because it's really important that we see the interplay with the 0 to 19 team, because we do have a universal offer that requires us to do the mandated checks, but also if we, from a health perspective, know that children are home educated, then additional measures can be put in place. So, Rachel, could you just share that on to assure Councillor Green further?
Which don't have the mandated visits, that we're aware of the home education, and that liaison is really important. So I'll take that back.
Thank you. And just to highlight a piece of good practice from a community pharmacy perspective as well, they have a really important role in this, and I quite often get a message from community pharmacists saying, I'm concerned about this person, they are requesting their medicines more often than they should, or they haven't had their medicines, and often they also have quite direct contact with some of our more vulnerable patients who sometimes are leading more down we were talking about multiple drug misuse and things like that. There's a key role in there in the system too. So I think it's just, again, an example of how useful everybody taking note can sometimes be.
That's really positive. That's really helpful to hear as well, because I know you've mentioned before about, the quicker we can get in, the better, really. We shouldn't be waiting until it's reaching crisis point, or that we're having a strategic statutory safeguarding review. And people, it takes everybody in the whole system, doesn't it, to work together. So thank you.
Anybody else wish to contribute? So thank you very much. I think that would mean that we are assured of your report, and please carry on as you are.
Thank you.
Yeah, thank you. Okay, so my agenda, where's my agenda disappeared to? It's here. So that brings us to item 8, which is the forward plan. So within the agenda pack towards the end is the forward plan, and you'll see that we've got a number of things that we know which are coming. Our general principle is that we would like usually to have 3 main items on the agenda. So there will be times when there is space with enough notice to take items from other partners. If you think that you've got something that would be good to share, this is one of the forums in Northumberland where we can talk about these things. There are others, but we're always happy just to take any suggestions of things that other people would like to share. So please contact Jill or I or Paul if there's suggestions there. The next meeting is a formal meeting. The March meeting, when I look, I think we have a small time for any formal business to achieve, and then that one is going to be a closed development session. And I think those closed development sessions are really useful because it allows us to do some of the developmental work and get us all thinking along the same, especially around the Institute of Health Equity work that we're doing. So that was on the forward plan. Did anybody have any things that they would like to say on that? No. We have no urgent business, and therefore the last thing to say is the date and time of the next meeting is Thursday the 12th of Feb, so it's not long because we're late with this one. So I apologise for that. You're going to have to come back fairly soon. So we'll have the next one, and that's here at 10 a.m. on Thursday the 12th of February. Thank you very much, everybody.